I want to thank Karen Rubin very much for asking me to talk. She's always been such a leader in telehealth in the United States and also in the world, and also Joe for moderating his panel and also his endless help in the state of Pennsylvania, which still needs additional help. And it's a pleasure to be here today. And like my colleague, Lori, I'm trying to use the technology and practice what we preach. And I serve in a variety of capacities at UPMC, but I'm still an actively practicing colorectal surgeon. And people in colorectal surgery love telemedicine because the patients can hide from us. We have not yet invented the telerectal examination, so that's why they use telemedicine. There's a lot of upside to this. And I also am on the board of the American Telemedicine Association, and I actively use telemedicine throughout my practice. And just a bit of context here, it was fascinating hearing the other speakers and what their experiences have been so far. And at UPMC based in Pittsburgh, we are an integrated healthcare system. The largest one is Kaiser, we're the second largest one in the United States. So we both deliver healthcare, we also pay for healthcare. We cover about 2.7 to 2.9 million lives on the insurance side. And likewise, we employ a large array of physicians, about 3,600, 10,000 nurses, have 22 hospitals and 600 care locations. And so we too are at risk as a delivery system and as a insurance system as well. And one of the big modalities that we're looking at right now, we are certainly looking at the patient portals with American Well. And the other main thing that we're looking at right now is remote monitoring. And I find this to be a fascinating topic. It's one of the projects I lead for UPMC. We are very near a go-live date for remote monitoring right now. And we went through quite a large tender process and selected a vendor named Vivify. And what we learned in the process of remote monitoring is that this is about as far upstream, so to speak, as you can get with patient care. You are taking healthcare back to the home. You're doing it asynchronously when the patients want to do it. And you're also getting a lot of bioparameters and other types of readings from the home. And this is one of the earliest warning systems that we've ever seen about long-term patient care, preventative care, care management, care coordination, and the like. And so we feel that remote monitoring is one of the prime strategic initiatives that we have at UPMC, not just for telehealth, but also how we look at long-term care and risk management in general. And throughout our time in looking at remote monitoring, what we learned is that, and this is really the point of why I wanted to talk this morning, is that for remote monitoring, we hear a lot about it. And there's a lot of excellent examples of remote monitoring throughout the United States. In fact, I was just in Norway and Sweden. I got back on Saturday, and there's a tremendous amount of activity in the Nordics as well, and it's other parts of the world. But what we've learned is that remote monitoring goes far beyond just the vendors. They're critically important, but it's the operations behind the scenes and also the financial modeling to support it. And we've always wondered, why is not remote monitoring at the population health level, 20, 30, 40,000 patients? Why is this not a very large risk mitigation strategy for the provider side, an engagement strategy for your HEDIS scores, a care management side for your payer as well? And what we've learned is that the operations behind the scene and the financial modeling are absolutely critical. And I wanted to get into that just for a few minutes here. On the operations side, one of the challenges that we've seen with our remote monitoring, and we've been doing various forms of it for 10 years at UPMC, is that the call center functionality is critical. You need a very large, intelligent inbound filter to handle this. And we had 2 different call centers handling the inbound calls. We have 6 or 7 call centers overall at UPMC, but there's 2 dedicated remote monitoring centers of relatively small size, and we've combined these. But what we've learned is that these call centers are the filter, or it's a level of protection between the inbound data from the patients and the front lines of medicine. So while I'm on this call talking to you, am I getting vital signs, low blood pressures, high temperatures, weight gain, and the like, or patients saying, please call me back? And so we believe that the call center design in the middle between the front lines of remote monitoring, the front lines of medicine is absolutely critical. And the features of that are many. It can be education, teaching, medical reconciliation, handling the actual remote monitoring devices, and responding to the data and alerts is critical. In the future of this as well for remote monitoring, when people talk about streaming analytics and population healthcare, we believe that streaming analytics also has a role in this remote monitoring call center about tying together the data that's coming in. It's not just the alert data, but it could be the time of the alert and also the time of the phone call. It's tying together data points that we don't even understand how they correspond to one another. And the second part of the at-scale remote monitoring that we've seen at UPMC is also the financial modeling behind the scenes. That I work for the delivery side as a physician and the remote monitoring project, and I also work on the payer side as a physician and also as one of the sponsors of the remote monitoring program. And what we're actually seeing right now is that my job as a payer is to actually kind of put myself out of job as a physician. And it's a very strange balance right now, because the more successful remote monitoring is, the less healthcare utilization you actually need. And that does certainly include physicians, hospital beds, and outpatient. And it's how you balance that delivery of remote monitoring versus what you're currently doing today as a delivery system is a delicate balance to get going. But when we get into risk arrangements, be they bundled care, penalties for readmissions and the like, it'll become easier to have that discussion. But certainly in any large system right now, especially the integrated systems, remote monitoring for all of its benefits does pose a risk. And it's something that you're seeing throughout the United States right now, that those folks that are using remote monitoring, that people are starting to understand really the long-term impacts to readmissions, physician utilization, hospital resource utilization, and the like. But we do believe the real positives here are what the patients want, that remote monitoring is taking healthcare back to the homes where it belongs. And looking at the technology, they're going to be coming up with technologies. It's going to be every conceivable type of technology. You could wear something the size of a Band-Aid that measures your temperature, your heart rate, your pulse ox. And yes, we're getting very close to transcutaneous glucose and the like. But the technology is going to be feeding us more and more and more data. It's how we make sense of it on the inbound side of it, the call center, and how we model it so it makes sense to our companies and our delivery system. And those are the critical features that we're seeing right now. And so our priorities in going live right now are obviously for congestive heart failure, where most folks start. And we've been doing this for quite a while right now. And we're also looking at other programs such as advanced illness care, which is a precursor to palliative care, certainly COPD, diabetes, maternal fetal medicine, tobacco and smoking cessation are absolutely critical. And one more comment, or a few more comments about remote monitoring. What I've described is our strategy about how we re-engineer this as a system. And the two big things that we're seeing now as well are that you need to have a bring your own device functionality. The minute you have kits and cell phone lines, which are excellent, and many of the vendors actually use these and have these and deploy these, they're expensive. And if you're a payer, you've heard before about an additive service, you can't just keep adding more services onto the system. So the more that you can use an integrated bring your own device strategy, so the consumers are the ones providing the technology and the connectivity, will be critical. And so overall, it's this sequencing of service lines, adding a BYOD, understanding the modeling, and creating a call center that filters this is actually how we view remote monitoring at scale in the future. And it's very exciting. I think the endpoints, I don't see an endpoint to this, but what I truly want personally is to see 5 to 10 to 15,000 patients on this, and to watch population health going upstream with streaming analytics in the call center to provide the earliest warning for preventative care, long-term care, care management, and the like. And so I'm happy to answer any questions after the last speaker speaks, and thank you very much again for having me speak today.